yes, what I want to do now is just to bring an idea on the topic. It's not our experience. We will also add our experience maybe tomorrow when we have the experience of the facilities. It's just some ideas on a theory level. What do we understand aftercare and what could be important. So there are many definitions. I have here a definition what could be aftercare. It would be a plan to support someone in the early recovery, because recovery we always see long time, not 1 year, 2 years. It's a long, maybe lifelong process. So aftercare is already early recovery, very important to prevent the relapse. And this is also the biggest obstacle because normally it doesn't work. And then provide assistance in the planning of future social inclusion. So we see that this is also not something easy, because this is something very wide, with the goals, to help in the planning of the life goals. And the aftercare plan should include a lot, activities, interventions, resources to help the recovering person cope with the trigger stress, and especially with drug addiction, the craving, which always occurs after a longer phase of the mostly residential treatment, because we also have persons who are in aftercare after outpatient measures, but mostly we talk about aftercare after a residential treatment. And as we see that this is a lot, we also see the limits, because we know in life if we want to reach a lot, we have to go step by step, and if we are too ambitious, it won't work. And this is also sometimes an issue for aftercare. We often have patients, they say, yes, I will do and this and this. I have a plan that the whole day is structured, and then it's too much. And that's also a possible incidence for failure already. So what is the terminology? We say aftercare, which in the end is not really right, and therefore in the professional world this has changed, and the expression continuing care is now more used than aftercare. Continuing care means a continuous therapy, which then starts with different measures. And as I was talking to the Hungarian colleagues, I think they are a very good example, which we saw about these continuous measures, because there's the pre-care, some people come and have the first contacts, they get motivated, maybe they go to another long-term treatment, residential, and then they come also back, and in the same systems they can stay with some therapeutic support. So continuing care means that the treatment is a long process with different steps, and supporting the idea that the active treatment continues in this phase of aftercare. So sometimes patients also say, I have enough of treatment now, maybe I do something else, but we have to be very aware that this is important and necessary long-term phase of treatment. And the continuing care is provided in a variety of formats, modalities, and certainly they have to be tailored towards the personal needs. This is even more than in the residential treatment. If we have one style of aftercare we offer, we will fail, because people are so different and have different necessities, and sometimes aftercare can maybe mostly to find a job and have some job education, and for others it's maybe necessary to have very intense individual therapy. So this can differ a lot and has to be tailored individually. So what could be possible measures, and I start with this because we have a lot of success with this. It could be ongoing semi-residential measures. If we have residential treatment, often the gap between the very safe situation and the very free situation then after the residential setting is not appropriate, and therefore semi-residential measures are sometimes quite good. It has the limits often about the bureaucratic situation, because sometimes there's coverage of cost for a therapy, and it would not be possible to have this only for some days, So there are limits, but I think that this is a very good way where patients can also be in the group they know, they are with, in a familiar situation, and it's quite easy sometimes to create motivation for this if they are basically motivated in the therapy. And then also some programs offer daycare programs then, so patients would come and don't stay overnight, but spend part of the days for some activities, for some group activities, therapy activities. And certainly what is always essential is the outpatient individual and group therapy, ongoing therapy, and we should, I think, motivate the patients immediately that this should be on a long-term basis, not maybe 2 months, 3 months, but 2 or 3 years. And we know that the success is always very much connected with the time frame. Then we have the self-help groups. This is something maybe different in the countries we come from. In Austria, people don't like self-help groups very much. It's interesting why. Maybe I think because they have a very clear structure, and the Austrians don't like the clear structures too much. But this is something which works extremely good always in the United States, or also in Great Britain. People go to self-help group. I don't know in Croatia if it works better,
No.
Here, also not, yeah. So maybe it's a kind of mentality also. But we know that in the end it's a very good kind of aftercare, and the ones who are in the self-help group, especially anonymous alcoholics, over many, many years, they are very stable, and it's a very clear idea and framework. Then there could be interest groups. We see very much interest groups is easy. It's now patients have WhatsApp groups, they do activities, they inform others what they do, they meet again. So it's a kind of not so structured way often to meet and to keep possibly a good style. It can also go in the other direction, that the interest groups then find different interest again in where are the good drugs to purchase or something, but normally it's a positive thing. And then this is something which also exists, but was maybe in former times much more implanted. Life organization, some facilities, residential facility still have halfway houses, which would be another thing like semi-residential or sober communities, living communities where it's clear that this is an abstinent way of living, which could be one important step. For many, then, very important is also the ongoing medical treatment. We have a lot of patients, I think everyone experienced this, who are in need of some psychopharmac treatment, and sometimes it's crucial that they continue after the residential phase where it's controlled. So it's very important. Education, job organization, we have a specialist from Germany here for this, which is certainly essential, and sometimes not in the hand of the treatment organization, but then there's cooperation is important, and certainly the ongoing healthy activities. So we always are happy and see this as a good organized aftercare. If we meet former patients during our hikes, this could happen. Even when we go in the mountain huts, it could happen that we meet someone who has been here, and so this is very important. And also the Hungarian colleagues do a lot to motivate to keep these healthy activities, which is also not only the basic therapy, but creative therapies, dance, creative work, artwork, which is very important to have something for the spare time, because many people relapse because they don't have good plans for the spare time. Here you see, this is the water for the kayaking. There is enough like this, when the sun is very green, yeah. Uh, this is to promote the kayaking, but we promote it also as like the healthy activities. Yes. So, what is the criteria for success? And we have to be clear: the aftercare is not, or the continuous care is often not very successful. And the essential thing is to create the motivation. And we often hear this, that patients say, we have enough of therapy, and that's very essential. How to create the motivation? Possibly, maybe also through the therapeutic contact, if there's a good contact and people want to stay with their therapies for a longer time. This is very important, but also to, in the semi-residential phase, for example, to further connect into these healthy activities. And maybe this is all, I think, very important for discussion, but I think that the individual planning is very essential, and early planning, that the planning should start, maybe even from the beginning in some way, that there's an idea what is a long-term plan, 1 year, 2 year, just then brainstorming idea, where do I want to go with the therapy. And then, very important that a crisis intervention is ready available, and also a treatment of relapse. And I went through a little bit the international data, and the minimum of relapse within also the first months after residential treatment is with around 60%. I believe, because sometimes even not detected, even higher, So we have to be aware that it's not the average, that the addicted patients after therapy do not relapse, but they do relapse, And then some even still say a relapse is a failure for the whole therapy, which is not, certainly. And it's very important that we have a very fast intervention for the relapse. And when our patient who will be there on Thursday comes, he also had a relapse and is in this program still, so we can discuss with him how important this is. So stopping the relapse, I think, is very essential, and we have to work with the patients before that they know exactly what to do when relapse comes. We also know that sometimes then this gets a kind of continuity also. A relapse, there's the recovery from the relapse, then there's the next relapse, and then we have to think about other measures. But this is the continuity, I would say, of care, And for if there's relapse, there's no other really good idea than further therapy. We always say you have to admit that then therapy was not enough. But we offer this, the immediate treatment of the relapse, which works well and can bring people back on a positive in a positive direction. Because if the relapse takes too long a time, mostly all the achievements of the therapy vanish very fast also. So keeping continuity of treatment, I would say, is very essential. So what do we see now for the NPS consumers? And in the end, what I understood also about our discussion about residential treatment, and so we have to know that these are sometimes other clients, different clients with a different background, but in the end, we did not now in our discussion, as I see it, develop such very new ideas for the treatment, but the treatment has to be adapted individually always. But the real problem was that there was insecurity about are these people still we want to treat going on to consume, do they consume secretly? What do we do if they consume secretly? And so if this is already a big topic in the residential phase, it's certainly a big topic for continuity of care. And we also detected in Budapest different user groups, and I think it's very easy for a kind of polytox group, which is highly addicted and also consumes new psychoactive substances because they consume everything, and then so to say there is no speciality for the programs. But we also have these users who don't think they are really addicted. They consume maybe a lot and get psychic problems. They consume in the weekend, but don't consume all times. They say they are not addicted, and if we are, objective, we have say they have maybe a problem with these drugs, but it's not an addiction because they have the phases where they don't consume, but still there are essential problems. So what also is to discuss, and the topic is the sobriety, which will be an essential issue. And I think we can only be successful if we aim at least for temporary sobriety. Sometimes with these patients, it doesn't make sense that say, will be sober for your whole life, but you can say we need a phase. We need a phase for 3 months, and especially after the therapy, we need a phase where you don't touch drugs, and then we cannot control. That's another thing. And then it will also be a topic that the consumers will say, yes, but certainly I don't have an alcohol problem. We know this also from opiate users. They say, yes, we will consume alcohol because it's not a problem. But here it's even more, because some will say, yes, but I know which party drugs are not harmful for me, and to have 2 or 3 beers, will also be an issue. We just had a young guy who came from the United States even, and was Burgis client, and we had to have an idea about controlled drinking, because he was very young and said, I will drink alcohol anyway. He had used other drugs, and so then it's a test. How does this work? Mostly very complicated, and but very essential for the therapy. So this is one point, and then it's also addressing the recreational activities, because certainly these patients, they will go out still to partying, and it's very interesting. Also the patient we will see knows more about, there is also a movement about sober partying, about going out to events and not touching any psychoactive substances. So this is also maybe an ideological thing which we can bring into the therapy, which we can bring as an idea. So here we see the biking, this is the more, you see we are high up here, the more strainers, and here more in the flat, but they had also to go up, so we have all the environments here. Yes, so with the NPS, maybe it's more like in all the continuity of care, importance the therapeutic relation, and then even more in the aftercare, trust and compliance. And we all know that we have the patients who come and tell you stories, everything is working so well, and it's not true. We always think, why do they pay some money and why do they do this? But we all know about self-deception we have sometimes in our lives, and this can get really in a pathological way. And if we see this, and I learned that for many here in the project, it's important to have a kind of tool, which always is the urine test. We say, okay, it's clear the lady is sober or not, but with the NPS, we cannot say it because there is no testing. And we are also not the experts to know immediately. We know if someone is drunk or has taken cocaine or opiates. We can see it, from our experience. But here it's very unclear what is the reaction, what are the drugs even, you know, they change, we know, we learned also this, they change within all 3 months, you know, the providers, you know, they also announce that the one drug will be on the blacklist, so they are just developing a new one, which then will be available 2 months later. So this is not so clear for us. So these are all, I think, important points then for our discussions. So we can say, are there therapeutic qualities which are helpful in the development of a trustful basis, so that the patient is motivated to also speak openly about the situation when he consumes, what he consumes, not to hide it, which maybe is even could be easier in the aftercare in a relation than in the therapeutic community, where this is a total no-go and very restricted. So the other question would be, is there a way to minimize the negative consequences of the possible undetected hidden events of relapse? Because certainly the therapy fails if the hidden process continues long time and is not, as it would say, on the table. So we should motivate the patients always, especially for the aftercare, to not be ashamed if there is relapse, to talk openly. And even if they have another direction than we think is good, you know, to talk about it, because sometimes they just want to please our needs and say, yes, we do fine. And so, but they have different ideas. So we have to be very careful that they don't, in a way, try to fill our expectations, you know, which then certainly cannot work in the therapy. Is there also some criteria to stop an aftercare phase if we say that it goes wrong for a long time? What do we do? Do we say this doesn't make sense like this? You know, if we see, because I also know these patients who come for residential treatment and then they say, I was already 7 years in psychotherapy. I always told the therapist I take drugs, I drink, but he never took it serious, you know. So in some way it was wasted time. So I think it's also a kind of obligation from our side to find out what's wrong and to address it. And also, should there be efforts to keep continuity in such a case if it goes wrong? What can we do to keep continuity? And maybe in the system, it certainly is essential then we say you need more of other therapy. You know, aftercare doesn't work anymore. You have to go back maybe to residential treatment or do something different. We need a new strategy. So, outlook. We also can ask what is the impact on the COVID pandemic on aftercare, because I think aftercare was much more hit than even the residential treatment. We had to close our facility for 2 months, and know that all the others, I think, worked through the whole pandemic. But with the aftercare, it didn't work anymore. It was mostly online. We know that we are all bored by the online meetings after 2-3 months, you know, and the same I think is for the therapeutic sessions. It's very different. Important part of the aftercare, these meetings, you know, I don't know if you could not have done it, all the activities in Hungary during the lockdown. More or less, yeah. So very difficult situation, much more, and certainly all people moved back, you know, some for them positively, some negatively, you know. We can see we can think about what was the impact of the therapeutic continuity also of the NPS consumers. You know, the NPS consumers had it more easy, maybe even in the pandemic, to receive their drugs, because they can get it sometimes on the internet, you know. So we know that the alcohol consumption was raised, you know. Illegal drugs went down because in the pandemic certainly persons consume the drugs which are more easy to achieve, And then we certainly, because we are very proud of our project, we can say how can Handle contribute to raise their motivation for continuity of care for these NPS users. So I think we can take a part to through our work to also have an idea how to better motivate the users. Yes, and that's always good, about aftercare and personality development. And you see the mountain, we can also walk up here. Here we are at the first two mountains of the Alps here. This is on the peak of Rax. And Hilary was the one who said it's not the mountain we conquer, but ourselves. So this is for the outdoor adventure therapy a good idea. We don't work on the physical activity, but on ourselves if we conquer